Good morning.
Morning, Dr. Tully.
Hi, how are you?
I'm good. How are you?
I'm good. I'm so glad we are making this happen. My goodness.
Yes. Thanks for doing this.
Yeah, no, I appreciate your team's flexibility as well. And I see lots of people on the call, so that's really exciting.
Yes. Yeah,
Um,
so I think we're ready to get started. The recording is started, so whenever you're comfortable starting.
yeah, let me test out my screen sharing, and then I would request a short reprieve. I just came from multiple back-to-back events,
Yeah,
and I like to take a very quick bio break before we start. But let me quickly test my screen sharing.
yeah, no problem.
Oh, it looks like, oh no, I won't do that this time. What is the window? Let's do the screen. Okay, so I'm sharing my slides. Can you see the main slide and the captions?
Yes, we can.
And I can see you as well, so that's good. Okay, that's great. I am, as is tradition, I'm not able. Oh, I guess I can monitor the chat. Okay, excellent. You'll see me. I've got two screens, so if my face is going this, looking at the chat. Okay, I'll take this opportunity to take my bio break, and I'll be back in just 2 minutes. Thanks, everybody.
Sounds great.
Okay, can you hear me? All right,
Yes, we hear you.
wonderful. And screen is still visible. Is the sound okay?
The sound is good. We're not seeing your slides at the moment. I'm not sure if you're sharing those yet or not, though.
Oh, interesting. Okay.
There we go.
Okay, you're seeing the slides.
Yep.
Great. Uh, okay, and I can see the chat. So I will try to monitor questions in the chat. So good morning, everybody. I'll take 5 seconds to have some silence, and then that'll make it easier for whoever's editing the recording to capture the beginning of the session. Okay, good morning, everyone. Thank you for joining and giving me some of your valuable time. I shall be presenting a summary today, a quick overview of some of the sort of core evidence-based treatments for early psychosis. I have the chat window up, so if you have questions as I'm going through the slides, please don't hesitate, put them in the chat and I will attempt to answer them as we go. Or I may choose to wait for the end. And as usual, I'll try to save about 20 minutes for us to have a discussion before we end our session together. For those of you who are just meeting me, I'm Dr. Laura Tully. I am a volunteer clinical faculty at the Department of Psychiatry, UC Davis, where I was previously a full-time faculty and director of clinical training at the early psychosis program there. I have since left and am now VP of Clinical Services at a digital mental health company called ChatOwl, where we're attempting to develop treatment for delivery through applications and leveraging artificial intelligence. Okay, so quick outline of what I want to cover together today. I want to talk sort of broadly at a high level about the treatment standards for early psychosis. And then I'm going to go through a few categories of treatment approaches, individual interventions, and I'm really mostly going to be talking about CBT for psychosis, family interventions, ways of addressing client and family needs, group interventions with a specific focus on a guided peer support group model, and then a couple of items around treating really common comorbidities, particularly managing cannabis use and treating trauma. Because we're covering a lot, I won't necessarily go into deep detail in these each point here, but I have provided links and resources for those of you who are interested in following up on particular aspects. And of course, I have a limited time with you, and so I haven't been able to cover everything. The pieces that I'm not able to cover today, I have acknowledged at the end of the slides and put links in there for follow-up readings and familiarity, ways to familiarize yourself. So let's start a little at the treatment standards for early psychosis. And I'll just pause and say that many of you may have had the opportunity either to attend prior sessions with me live or watched the recordings. Some of the information that I'm presenting today has also been presented in those other seminars in more detail. And I have bookmarked that where relevant. And some of it is new information. So for those of you who haven't been able to attend or watch those prior sessions, I encourage you to do so if you're able to. And if not, it's okay. I'm providing at least an overview here. So from a high level, what are the treatment standards for early psychosis? The very first tip is that the focus should be on boosting protective factors, ways to boost resiliency for these young people. And doing that means treating symptoms, maintaining physical health, limiting stress, improving coping skills, and increasing social support. And I've got some examples in each of these categories. And sort of addressing those kind of 5 main areas using certain techniques is going to promote resiliency and protective factors for your clients. Tip 2 is to do this by using evidence-based treatments. So very broadly, we've got, kind of treatments that target sort of physiology and biology, which might include medication and substance use management. Then there's psychological or cognitive interventions, including CBT, cognitive remediation, social skills training, and then environment and family interventions like case management and family psychoeducation, and a couple of different group modules. The third tip for treatment standards is to intervene as early as possible. So we know from the research that the duration of untreated psychosis, which is the time between a person's first psychotic symptom and when they get treatment for psychosis, the longer that time period is, the worse the person's outcome. And so duration of untreated psychosis, or DUP, is the single best predictor of long-term outcome. In the US, the latest data, the data that I have is the median delay between symptom onset and starting treatment is about 18 months. And just for comparison, the kind of median delay or DUP in other countries like Australia or the UK is somewhere around 3 to 6 months. So we've got a long way to go. And the earlier you intervene, the better, you know, the faster and greater the symptom reduction for that person, and the better the quality of life and functioning improvement. I think it's important to just quickly define what we mean by early psychosis. Very broadly, it's considered the first 5 years of onset after symptoms. It's considered a critical period during which treatment has the biggest impact. If we get into this early phase, you can focus on maintaining functioning rather than recovering functioning that was lost. And that's kind of the ideal approach. And this is what all the early intervention funding through SAMHSA block grants, et cetera, have been trying to do, is to fund counties, states, health systems in developing early intervention programs and shortening that duration of untreated psychosis. Tip 4 is for treatment standards is to use the coordinated specialty care model. This is a team-based approach. It's very clear from the data that team-based approaches that combine multiple types of care are most successful for people in the early phase of psychosis. The coordinated specialty care model was developed and broadly implemented across the UK, Australia, Canada, and Scandinavia, and then most recently the US. It typically includes community outreach and education, early identification, and a combination of evidence-based treatments for psychosis, using a multidisciplinary team that work together. The focus on intervention is in the first 2 to 5 years of onset. And what we know from the research data is that engaging in coordinated specialty care compared to what might be considered treatment as usual, so individual work perhaps, or medications only, leads to longer treatment participation, greater symptom reduction, and greater improvement in quality of life. And really there was a landmark study that supported these, that came out with these results here in the States, called the Navigate study. It was the RAISE study that implemented the Navigate program that was funded and driven by NIMH. And I've got some references here at the bottom of the slide for those of you that are interested in diving into the details. There are variations of the coordinated specialty care model across the states. I've listed the 4 main ones here. The PEER program, which was developed over in Maine, primarily led by William McFarlane, the Navigate program, which came out of the RAISE project, On Track New York, led by Lisa Dixon and colleagues, and then the EDAPT program, which is the variation of the coordinated specialty care model that we implemented at UC Davis. How do these things differ? Well, it's across a few kind of nuanced things. What is the age of clients served? You can see here that each of those 4 programs, we all roughly cover this sort of adolescent to young adulthood period. Some of us go younger. For example, at EDAPT, we go down to 12. Other of us go older, somewhere between 30 and 40, but we're all covering that kind of critical developmental period of adolescence to young adulthood, because that's where psychosis onset typically happens. And so we want to try and capture those people in the early phases. Programs also differ on the stage of psychosis that's served. So some of us serve both individuals at high risk, so they might have attenuated symptoms, but haven't yet developed psychotic level symptoms. As well as folks who have had their sort of first episode, and some programs like Navigate and On Track focus on folks who have had a threshold psychotic symptom. And then there's some differences in the kinds of psychosocial interventions that are provided. So the Navigate program uses a specific kind of modular manualized approach called individual resiliency training, which is CBT based, but also pulls in recovery oriented skills development, psychoeducation, etc., versus a more focused CBT approach. And then the ways that family are involved differs a little bit by those programs, but all of the programs have a family intervention element. Just as a refresher, this is a visual representation of the coordinated specialty care model specific to what we do at UC Davis. And so you can see that we essentially surround the client and family with multiple types of care that is all coordinated as across the team. And just as a reminder, family is defined very broadly, and that definition is driven by the client themselves. It could be sort of more traditional family, biological family, parents, etc. It could be chosen family. It could be more broadly support persons. But the key takeaway is that it's not just the client that's involved in treatment. We know from the research data that having a support network involved as well promotes better outcomes. And you can see that we have coordination, our physician work, our lead clinician work, supported education and employment, family advocacy. So this is family members with lived experience of caring for someone, a loved one with psychosis, a peer case manager. So this is a person with lived experience of psychosis and or navigating the mental health system, and then a variety of group therapy interventions available. We also coordinate with primary care, do a lot of community outreach and education, and the clinician manages a lot of relapse prevention and crisis management. So you can see there's a lot of different integrating factors that are part of this model. Just a little bit of information about what the treatment standards are for what we call CHR. This is our clinical high-risk individuals, so individuals that are showing those attenuated positive symptoms but haven't necessarily had a full threshold psychotic level symptom. But there's been a lot of interest in the research around whether we can prevent or delay the onset of psychotic level symptoms. Some of the research looked at antipsychotic medications, and a meta-analysis here indicate that it does not significantly delay the onset, and the significant side effects outweigh any small benefit that might be there. So it is now generally not recommended to be using antipsychotic medications prior to a full threshold psychotic symptom, but it is recommended to use medications to address comorbid issues. We know that the vast majority of individuals at high risk also present with clinically significant anxiety and or depression, and so it's worth addressing those pieces to kind of bring the stress down. The data do clearly indicate that CBT for psychosis does tend to delay psychosis onset. The effect size is small, but it is there. And separately, we know that CBT for psychosis appears to be very effective across the psychosis spectrum at reducing positive symptom severity and helping improve some functioning. Very small effects on negative symptoms, but definitely some data around positive symptoms. We know that family-focused therapy, which I'll be talking about in a little bit more detail later, also reduces attenuated symptoms and comorbid anxiety. This is a model that came out of David Miklowitz's work, who was originally at Colorado University and now is at UCLA. And we know that combination approaches, similar to how the coordinated specialty care model works, where individual, family, supported education, employment, and meds tend to reduce symptoms, although both of these references, the references that I have here, are not randomized control trials. So they're more different kinds of treatment studies, but the data are promising. There's also some information here about treatment standards for mood disorders with psychotic features. So there have been a couple of trials that indicate CBT plus antidepressants like fluoxetine tend to be better than CBT or fluoxetine alone. We've also seen similar studies around antidepressants plus antipsychotic or ECT in the acute phase tend to reduce symptoms, as well as acceptance commitment therapy and behavioral activation, reducing symptoms in folks with psychotic depression or depression with psychotic features. Similarly, for bipolar disorder, there's good data out there to indicate CBT approaches and family-focused therapy approaches, including psychoeducation, do tend to bring the symptoms down across the board, so the mood symptoms as well as the psychotic symptoms. And I've linked a review here for those of you who are interested in seeing more detail on that. So just a very quick summary of treatment standards. We know from the data that coordinated specialty care is appropriate and effective for individuals with schizophrenia spectrum diagnoses who are early in the course of illness. We have some data to suggest that combinations of treatments similar to the way we combine things in the coordinated specialty care model may also work for individuals at clinical high risk, but it hasn't formally been tested in those individuals or in individuals with mood disorders and with psychotic features. Now, those of you who are working in the context of these early psychosis programs, this information will be helpful depending on the kinds of clients that your program accepts. If your program does accept clinical high risk, I think it is worth implementing the model. You may choose a stepped care approach based on severity. Not all clinical high risk people will need all services. And so you can sort of do a triage approach, and that's something that's being actively examined in the literature, in the research space right now. And again, if you are also including folks with mood disorders with psychotic features, maybe looking at some of those family-focused therapy approaches where we have some pretty good data would be a good approach in tandem with some of those other elements in the coordinated specialty care model. So let's talk about individual therapeutic interventions. I'm going to be focusing on CBT for psychosis, just a quick refresher. There are a couple of other approaches, including the IRT, individual resiliency training that came out of the Navigate program, which I don't have time to go through today, but have linked materials. So why would we do CBT for psychosis? Well, psychosis symptoms are conceptualized as distressing and stigmatizing interpretations of intrusions on normal awareness. And so the translation of that is similar to the kinds of thinking traps or thinking perspective, cognitive biases that we see in other conditions like depression, anxiety, eating disorders, etc., that are addressable using cognitive behavioral techniques, are similar to those that we see in psychosis. It's just that they are culturally unacceptable or stigmatizing interpretations. What this means is that we can apply cognitive behavioral techniques to generate alternative and more adaptive interpretations, as well as normalize those experiences. And that's what's been done. And there's a very clear literature that indicates that CBT for psychosis reduces positive symptoms in first episode psychosis, established psychosis, and those at clinical high risk. And I've linked one of the meta-analyses here. There have been follow-ups, and I believe that the Cochrane reviews have also released something showing the same data. As I mentioned earlier, the impact on negative symptoms is much less clear. There have been a couple of trials recently, but there is a very clear impact on positive symptoms. And of course, CBT techniques can also be used to address comorbid symptoms of anxiety and depression. Quick refresher that the three key ingredients of CBT for psychosis include psychoeducation to normalize psychotic experiences, reduce the stigma, and as a result, reduce distress. There's also the importance of a collaborative development of a case formulation to inform understanding of the psychotic symptoms and make sense of the experiences, and then working on the acceptance of those experiences and reducing associated distress or conviction. And this may be better than attempting to change the symptom occurrence itself. So really trying to take a third wave view where it may be less about changing or challenging cognitive distortions and more about acceptance, mindfulness, and choosing whether to engage in change strategies. If you want to learn more about CBT for psychosis and haven't had the opportunity to watch the 3-part series that I have done over the last few months, I've linked it here. At least this is part 1. I've also linked a very good CBT for psychosis fact sheet here that gives you a very nice overview of it. And I've linked a couple of books that I think are particularly helpful because they're written to be self-help guides. And so they're written in ways that are accessible for a non-clinical audience, which I think is always helpful for me as a practitioner because it can help me use accessible language and accessible approaches to the work that I need to do with my clients. So I think these 2 books are particularly helpful if you're starting to think about implementing CBT for psychosis. I'm going to move on and talk about family interventions and how best to incorporate family into treatment. I think this is a very, very important part of successful treatment of early psychosis. We have very clear data on it, and it's always been anecdotally in our clinic at UC Davis, our family interventions really tend to move the needle and keep our clients engaged. So I think this is a really important topic for us to spend some time on. I've got a summary here of the 4 primary family interventions that have been used, implemented, and researched. It's not an exhaustive list. There are other ways of doing it, but I think these 4 things are a good place to start. So the first one is multifamily group, or MFG. This is a treatment protocol that was first developed, I think, in the 1960s, but then adapted by William McFarlane of the PEER program in the 80s, late 80s, early 90s, specifically for schizophrenia spectrum disorders. The model essentially has about 5 to 8 families, including the client, meeting together over a 2-year period to learn problem solving, conflict management, and improve family communication. And it's done with this kind of mix of clinically kind of scaffolded group conversations and family peer-to-peer support and kind of knowledge sharing. So it's a really interesting mix. And in terms of, what is the primary mechanism it's addressing in order to prevent relapse and promote wellness, it's addressing this concept called expressed emotion in the family system, which we'll talk a little bit about later. Another family intervention that has been well researched is family focused therapy, or FFT. Some of you may be familiar with a different FFT, which is family functional therapy. They are distinct. Family focused therapy is much more structured. Family functional therapy, developed in South America primarily, uses a much more psychodynamic approach and is applicable in other scenarios. So just to kind of make that distinction for those of you who may be thinking, oh, I know FFT, it's potentially different from the one you're familiar with. It was developed by David Miklowitz and colleagues at Colorado and then now at UCLA. It focuses on family function in the context of supporting the client. So there is an identified client versus the family being the client, which is in traditional family therapy. You have your client with early psychosis and then the family around them. It takes a modular approach. The modules include psychoeducation, communication enhancement, and problem-solving skills. And throughout those modules, there's a focus on wellness planning and relapse prevention. We also, at our program at UC Davis, implement what we call the family support group. This is for family members only to attend. It's led by our family advocate with lived experience and a clinician or our medical director. And the goal of the group is to provide psychoeducation and general support to family and support persons, as well as providing a space for problem-solving facilitation through a lived experience lens. So often we'll have families in the room who are at different points in their journey of supporting their loved ones. You might have folks who are right at the beginning where their loved one has just had their first psychotic symptoms and they've just joined the clinic, and then other families around the table may be, in their 2nd or 3rd year of supporting their loved one and have seen more progression and gone through some of those stages. And there's this really beautiful interaction where families at different stages can provide support, lived experience, and validation for where the other families are in the process. And it can be really powerful. And it could create community as well. For many folks, as caregivers, it can feel isolating. It can feel as though no one understands the efforts and needs that you're meeting for your loved one. And so having that family support group, I think, can be a really good way of building community and validation. We also do a lot of family advocacy and case management. So the family advocate is somebody with lived experience of caring for a loved one with psychosis. And this person is a powerful source of validation and support at an individual level. So our family advocate will meet with individual family members and just really connect with them. And the advocate is the voice of the family in the team meeting room. They advocate for what the family or the caregiver or support persons might need to maintain wellness, which could shift the way we're recommending treatment. You know, the clinician might be saying, hey, the caregiver needs to be present for every therapy session so that we can do this family work. And the family advocate might say, right now, the caregiver is just not in a place where where they have capacity to do that. And actually, I think it would be more helpful for them to receive XYZ. And it allows the team to have a discussion where multiple perspectives of the family system and client are being considered as treatment recommendations are developed. So why are family interventions so important? Well, we know from the research literature that the most successful outcomes are typically associated with clients who have a support network around them. As I mentioned, family is defined very broadly and by the client. And family interventions can do a multitude of things. They can address high expressed emotion in the family system, which we know to be a relapse predictor. They can support the family in understanding their loved one's symptoms and how best to support them. So it's sort of psychoeducation and validation, normalization. It can promote effective family communication and problem solving skills, which really gets at conflict management. And it can support family members in their own mental well-being and life management, which in turn can reduce stress in the family system, which in turn can reduce the likelihood of a relapse or improve outcomes in general. So I've referenced this term expressed emotion a few different times now, so let's dive in a little bit. So expressed emotion, and you may see it in the literature as EE, refers to the content and expressive style of communications among family members. A family member is characterized as having high expressed emotion when they express high levels of criticism, hostility, or emotional over-involvement towards another identified family member. And what we know from the research, and there's been decades of this, it has been consistently associated with negative outcomes and higher relapse rates in individuals with schizophrenia. So I'll give you some examples. There are these really kind of common communication traps of high expressed emotion. And this is not unique to families with loved ones with psychosis. We can observe this across any and all families. And so you might see various versions of criticism where it could be emotive or interpersonal. So this could be expressing the desire for an interpersonal interaction through critical statements. So an example here is like, I wish you were more involved in family events, which can be perceived as a criticism of not being involved. And so one thing that we might want to work on is kind of reframing this phrase so that it's less critical and more positive action focused and a request. It might be character based, so you never do anything to help around the house, or it might be indirect, so alluding to a faulty behavior, like I'm so happy you did this task right this time. And there's hundreds of different versions of these, and we're all vulnerable to engaging in this kind of communication trap. And what's happening in folks with psychosis is that it's playing in the context of the vulnerability stress model. So an individual with psychosis is potentially more vulnerable to stressful environments, and if there's high EE, it can push them into experiencing symptoms based on where their level of vulnerability is. So it's this idea that these things are present in the real world throughout families, but some people's brains are more vulnerable to them than others. Other common communication traps of high expressed emotion under hostility is sort of frequently or consistently using irritable or angry tone when communicating. It's really more about the tone than about the content. It could also include lots of sighing or other kind of nonverbal information that creates a sort of hostile or aggressive dynamic. And then emotional over-involvement is is really represented by kind of repeated checking in with the client and sort of kind of hovering or helicopter behavior that doesn't provide the client with opportunities for self-disclosure. So it could be a lot of like, how are you feeling? Did you take your meds today? Are you experiencing symptoms? How can I help you? Should we call your therapist? Let's do something. And it could happen all in one breath. And that can be very overwhelming. And I would say that all three of these elements, criticism, hostility, and emotional overinvolvement, have been shown to predict relapse and bad outcomes across multiple disorders, not just schizophrenia. It's present in depression as well. But the one disorder where emotional overinvolvement appears to be either neutral or positive predictor of outcomes is in folks with complex trauma or borderline personality disorder traits. So just kind of an interesting dichotomy there. So how do we address these communication traps? Well, the recommendation is to do it with family interventions, which I've already kind of summarized, but I want to dive into multifamily group therapy and family-focused therapy a little bit. So it was originally developed in the 60s, adapted in the 80s, and the goal is to address high expressed emotion in the family system by enhancing problem solving, improving communication, and reducing distress and conflict in the environment. There are three main stages of the multifamily group program. Stage one is joining. So this is about building rapport and alliance among the community group, so among the individual clients and families, and really trying to create a community, a sense of community in the room, in the group room. And one of the ways that we do this is we break bread together. So when we run our MFGs, we have dinner. It tends to happen in the evening because that tends to be when families are available. And we provide food, and sometimes you can have potlucks, and it can be a way to connect with each other culturally, in terms of family traditions, in terms of, you know, food likes and dislikes, and it can create this environment where people can just freely kind of share and get to know each other. So that it's a powerful tool for creating community is the breaking of bread, and that is how we facilitate joining. Then the second stage, and we do that at every group, by the way. So we start with a major joining session. There's also a lot of sharing of stories and you know, people asking each other questions. But we continue that joining process and the sharing of meals together throughout the program. Second stage is we conduct an educational workshop about psychosis for families. In the original model, that workshop is quite extensive and can last, I think, 1 to 2 days. Excuse me. We adapted it a little bit at UC Davis just to make it more accessible for some of our families who may not be able to take multiple days off to attend a workshop. And so we've kind of condensed it into a couple of kind of hour-long psychoeducation workshops that cover the main points. One sort of talks about what we kind of affectionately call Psychosis 101, you know, what are the key things that you need to know? And another is about relapse prevention and wellness planning. So how do we do that? And then we have a couple of other like specific workshops that people can engage in around things like cannabis management or trauma management or access to resources. But the main focus is Psychosis 101 and wellness management. We tend to deliver those live as part of 1 or 2 of the sessions in the multifamily group period, but they're also available for people to watch asynchronously on YouTube based on recordings that we've made. And I can include the links to those at the end of the slides here. And then the third stage is really the meat of what's happening in MFG, which is relapse prevention through the use of a problem-solving format where everybody attends. And this is very structured. So we use the kind of problem-solving rules, right? We define the problem, we brainstorm solutions without evaluating, we go through each solution and do kind of pros and cons of them. You pick a solution to try and make a plan of how to try it. So what happens each week is that we go around the room and we say, you know, what's one thing that went well for your family this week? And what's one thing that what's one challenge or one thing that could be going better? And then based on that sharing, the group will pick one thing that could be going better, which is essentially turns into the problem to be solved, to work on together. So essentially one family gets to be kind of in the spotlight and gets support from everybody else in the group at generating potential solutions for helping that thing to go better. What's nice about this is that, you know, each family over time will get focused support, but also many of the problems that families are experiencing are also problems that other families are experiencing. So there's still relevance for everybody. And it also promotes that community-based support rather than just coming from the clinician. It's facilitated by 2 clinicians to groups of anywhere between 5 to 8 families. We have done rounds of MFG with fewer families. It's really about fitting to your clinic. I wouldn't recommend doing it with less than 3 families in general. And in the original trials, it was done over a 2-year period. We have had some successes at doing shorter kind of curricula so that people can feel like they can engage more realistically. So we've made a few adaptations from the original protocol that I think are ways of us making this protocol fit our particular community of clients. Why would we do it? Well, it supports the gaining knowledge of psychosis and learning skills. A main theoretical foundation of MFG is increasing social network size and support by enabling families to benefit from each other's experiences and how certain solutions did or did not work for them. And having that conversation of like, well, our family structure and our resources include ABC, and so this solution really worked for us, but maybe this other family structure needs a different solution based on the resources and the culture and the structure that they have. We also know that across a number of clinical trials, multifamily group therapy based on the McFarnell model has been shown to decrease relapse rates and rehospitalization among individuals with schizophrenia and to improve overall family well-being over the 2-year treatment period. So there's very clear data to show that this is an effective intervention at the family level. If you want to learn more about it, I've got 2 main recommendations here. There's a great book that describes the protocol, the rationale behind it, how to implement it. I've linked it here. It's written by William McFarlane, so you get straight from the source. And then I've also linked the Peer Training Institute. If you or your program, your clinic are interested in learning how to do this, they do offer trainings for MFG. And some other aspects of coordinated specialty care in the context of the peer model. So that's MFG. Let's talk a little bit about family focused therapy, or FFT. So the goal of family focused therapy, similar to MFG, is to educate families about symptomatic presentation and offer tools to prevent onset and worsening of psychosis or bipolar disorder. Actually, the original development of FFT was focused on adolescents and young adults with bipolar disorder, and then was adapted to include adolescents and young adults with psychosis or those at high risk. The goal throughout is to integrate experiences associated with episodes in those diagnoses, assist the client and relatives in accepting the client's vulnerability to future episodes, accept the ways that psychopharmacology or medications might be involved to manage symptom states, and maybe address any kind of internalized stigma around that. It's also focused on enhancing social and academic functioning or occupational functioning, and recognizing and learning to cope with stressful life events that might trigger recurrences of the disorders. And so it's done in the context of the vulnerability stress model. And then finally, it's about assisting the family in reestablishing relationships after an episode. There can be a lot of grief, there can be conflict, there can be avoidance after an episode has happened or hospitalization has happened, because it is a significant stressor. And depending on the family structure and how they navigate stresses together, there may need to be a need to reestablish those relationships or create safety in those relationships. It is semi-family systems focused, so it does take from traditional family therapy theory that the dynamic of family functioning is a focus that needs to be identified, addressed, and adapted. But unlike traditional family therapy models, there is still an identified client. So traditional models tend to say the family is the identified client or identified patient, and you're treating the family dynamic as a whole. In FFT, we are recognizing that you've got this identified individual who is experiencing psychosis, and it's their symptoms and functioning that are centered during treatment, and how the family system can support that and navigate that effectively. It's quite a structured approach, which I like. It's fairly easy to learn and fairly easy to implement. Many of the elements in the psychoeducation, communication enhancement, and problem-solving skills modules are elements that you will be familiar with as a consequence of your clinical training. And so it's a very accessible model, and it has some very good handouts and structured ways of moving through. So I think it's a good option for implementing in a program if you don't already have a family-focused intervention. Why might you choose to do FFT? Well, we know from treatment efficacy studies that it results in a reduction in relapses and hospitalizations. It results in improvements in social functioning. It can support treatment adherence and, showing up. It can decrease the familial burden or the subjective feeling of familial burden of caregiving, and improves family communication, mostly through decreased expressed emotion and family discord. There's a couple of asterisks here that we do know that there are varying effects of expressed emotion depending on the ethnic and cultural background of families. So, as is always the case when considering the application of treatment interventions, taking a culturally humble, culturally informed lens and adapting as necessary to meet that family within their community culture, within their structure, is going to be more successful than just implementing the template in the absence of those cultural adaptations. It can also improve treatment interfering factors. So by pulling in family engagement, you can get increased treatment adherence, increased fidelity and practice of the skills that the family and the young person are learning outside of sessions. If you want to learn more about FFT, I highly recommend reviewing the treatment manual, which is freely available online and very accessible and nicely written, and it includes all of the handouts. I've got the first handout here where you would walk through it with the client and family of what are we going to do together, how are we going to do it, how often are we going to do it, and you can see that it is a 4-month protocol, weekly for 8 sessions, bi-weekly for 4. And really working on who's going to be there and how people will engage. You can also contact the Colorado Depression Center for training options. I've linked it here. They can provide a 1-day FFT training that is thorough and helpful and would set you up for success. I would say that it would be reasonable for experienced clinicians who may have already had some family therapy training or experience. You could use the manual, follow the manual, and implement pretty successfully. So I want to talk, we talked a little bit about clinical family interventions and with a focus on MFG and FFT, but I want to spend a little bit of time talking about addressing additional family and client needs and ways to do that. So we know that when our clients and families come to us, they're not just coming with clinical symptoms. They're often coming with additional life stresses and challenges. For those of us that work in underserved, historically marginalized populations, individuals in California who use Medi-Cal. These are individuals who are often coming with additional stresses like housing insecurity or employment challenges or food insecurity. And perhaps the family system has additional mental or physical health challenges that are being managed over time. And so, if we think about our vulnerability stress model, our job as treatment providers is to support the client and family in reducing stress where possible and managing stress where we can't reduce it. Life is going to include stress. Okay, how do we manage it effectively? And what resources are out there for us? Because if we can do that successfully, we're going to reduce symptom severity and reduce the chances of a future relapse or hospitalization. So there's a lot of things we can do here. It's mostly through case management, and this is a very important role in the coordinated specialty care model. So there's case management to support the family, could be supporting the caregiver in getting aid or benefits acquisition. For example, if the caregiver is spending a lot of time taking care of and meeting the needs of their loved one, they might qualify for IHSS. And so supporting that paperwork application would be helpful. There also might be opportunities for family medical leave, accommodations at jobs, things like that to support the caregiver in meeting the needs of their loved one. Case management can also include referrals for the caregiver's health and wellness. So if the caregiver is managing their own chronic illness or their own stress, we want to encourage them to put their own oxygen mask on first so that they're better able to support their loved one. We also can work with them at enhancing their support network. That might include family support groups, spending time with a family advocate, or supporting the family member in identifying people out in their community that they could reach out to and request support from. And then there's other things like meeting food insecurity, housing insecurity, or other family needs that would then reduce stress on the family system. The benefits of providing family support independent of the client is that it likely brings increased engagement. So our family or support network can help increase client engagement in treatment activities, both in terms of attending those activities and engaging in practice out in the community. There's an enhanced support system for recovery for the client, which can lead to relapse prevention support, could even lead to benefits acquisition and assistance with client needs. And I think perhaps most importantly, family support can reduce secondary impacts. So it can preserve the caregiver's employment and well-being and reduce caregiver burnout and compassion fatigue. So addressing the caregiver's needs, putting their own oxygen mask on first so that they have the capacity to support their loved one. And then I think the other thing that's really helpful is that when family are involved in treatment and they have the capacity to be involved, it can provide more information on treatment effectiveness. So we can get in-home observations on how things are going. Are there changes in symptoms? Are there new warning signs that maybe the client is not aware of or not able to share, but that the caregiver has observed and can share with us so that we can kind of get ahead of those potential relapse indicators. There's also a lot of case management to be done to support the client outside of clinical treatment. Benefits acquisition is a big one. Supporting the client in school or college paperwork and financial aid applications. Supporting the client in attending community events, and this could be case manager or the peer support person going with the young person out into the community to do things, and also doing in-community supported skills practice. So if the young person is working on a particular skill, be it a clinical coping skill or social skill or something else, the case manager or lived experience peer could go out into the community and do that. And there's a lot of different nuanced elements under each of these umbrellas. And the take-home message really is that we know that successful treatment doesn't just address the clinical symptoms. It addresses all these other sources of stresses that could be exacerbating those symptoms and again, boosting those protective factors. If a young person has financial support, if a young person has accommodations in school, if a young person is able to attend community events, they're going to be able to maintain and build that resiliency. There's also a very important role for supported education and employment. This is a specific role in the coordinated specialty care model. And this is a person with expertise at navigating school systems, disability rights advocacy, and occupational rehabilitation. So the work that your supported education and employment specialist can do can run the gamut anywhere from supporting a family in making IEP requests, or requesting school environment adaptations, or even working with school districts to find new placements that are better suited for that young person. There's also a really important role for disability rights advocacy in school or the workplace, where helping the client and family understand what their rights are and how do you request them, and what information is your school or employer allowed to know versus not allowed to know, and how do you navigate that. college applications, financial aid applications, resume preparation, job applications, interview prep, or even accompanying the person to those interviews, and everything that falls in between. Because, you know, a big part of what we're trying to do in treatment is to either maintain functioning out in the world through, you know, whether it be educational, occupational, social, or regain it or re-engage in those things. And it's really driven by what the client wants. What is the life the client wants to build? And then how do we support them in getting there? Which is the primary goal of any treatment, right? It's not just about symptom reduction, it's about building the life worth living. And if symptoms are getting in the way of that, okay, we need to address those. But if there are other sources of stress, then we need to address those as well. Another thing that I think is really important for the client, and it's really growing, is this idea of peer support and bringing in lived experience has really become front and foremost of our approach to early psychosis. And it's important because talking with peers who share lived experience of psychosis and share lived experience of navigating the mental health system, which is complex and frustrating, can be a powerful source of healing and validation. And we do have evidence in the research that these conversations with folks with lived experience, in the absence of clinical skills, in the absence of treatment, lead to a reduction in symptoms and distress. And so having this person on your team is really important. It's also clear that the peer support individual can advocate for treatment engagement, goal identification, in community skills practice, and advocacy in general. And they are the voice of the client in the team meeting. So similar to our family advocate, the peer advocate, lived experience individual is there to make sure that the clinical team are considering the client as a whole person, right? I think it can be, you know, the sort of traditional medical model can sometimes miss that. We get maybe too focused on symptom reduction or medication adherence, or clinicians can get too focused on, I need to do this manualized approach. And the peer support person can say in the room, hey, let's step back a bit and just really think about the fact that this is a young person who's going through this developmental phase and maybe dealing with some difficulties around what it means for them to have this diagnosis. Can we sit with that? Can we talk to them about that? And kind of slow the team down and help the team really understand, you know, what is the client's perspective? And also how, you know, the peer support person can share, you know, this is something that was helpful for me. This is something that wasn't helpful for me. How can we integrate that information with this particular client? So that's family interventions and ways of addressing additional needs. I now want to spend a little bit of time talking about group interventions. I've already mentioned one, which is the multifamily group intervention where both family members and the client are there. There are a handful of other approaches that I won't get to today, including group-based social skills training that can be useful. But the main one that I want to talk about is this guided peer support group model. Because again, what we know from the literature is that peer support and having people around you with lived experience that speaks to yours can be a significant, can lead to a significant reduction in distress and symptom interference. So the guided peer support group actually came out of the nursing community, and I've listed the kind of 4 main sources of information about it. This top one is the actual manual for running the group. It was developed to address challenges in individuals with kind of more established, long-standing, or chronic schizophrenia spectrum disorders, and we have adapted it to fit into the early psychosis model. But the principles remain the same. So if those of you who are interested, I encourage you to take a look at either the manual or some of these papers. It is well described in this second reference here. So you could start here and then choose to get the manual based on that. Why guided peer support? Well, peer support in general, we know people who share similar experiences can offer each other emotional and informational support above and beyond what a clinician can do. Peer support is frequently used in chronic disease management across multiple diseases. Think cancer, think Alcoholics Anonymous, think diabetes, and they are often peer organized. You know, the clinicians, the medical system are not engaged in those things. In fact, many of those models are quite protective against that. But one of the things that can be challenging for folks with psychosis is that a lack of guidance, a lack of support and scaffolding that is combined with some of the features of psychosis and those characteristics, which include social impairments and cognitive impairments, can lead to those peer groups kind of stalling or petering out and not really getting momentum. And so what the folks who developed this guided option did was they put in place a sort of minimal scaffolding, a minimally guided and structured group to address that issue whilst maintaining the fundamental ingredient of peer support. And as I mentioned, it was developed by the nursing community. So we implemented this at UC Davis, and we made a handful of adaptations from the manual that I'll talk a little bit about. We've implemented it, and it has been hugely successful and powerful, and a great joy. It's one of my favorite groups to work in. It's open to clients only, so there's no parents, no caregivers. We have typically kept it 18 years and up, although we have intermittently run adolescent peer groups. And of course, we can have case-by-case discussions, you know, perhaps as a 17-year-old that's ready to step into the group and would benefit. And it's really about what's the group composition, what are the topics that are being discussed, and how are they relevant to that person. We have 2 group facilitators, and one person is our peer advocate, so our individual with lived experience, and one person is a clinician. And we really support the peers, both our advocate and the individuals in the group, to collaborate with the clinician in how the group is run. And the sort of fundamental structure, and I'll go into details in a second, is really pairing group members together, supporting them in sharing their lived experience, and then coming back to the group at large to share those pieces. And then a discussion can follow from there. So I'll dive into that in a second. But you know, if you're going to implement this, it's important to recognize that your role as a group facilitator is to facilitate peer-to-peer interaction. It's not to provide clinical support. It's not to provide psychoeducation, although that does kind of get sprinkled in. It is to facilitate the group members interacting together. We can offer structured approaches and continuity without interfering with that process. So you might use guided discovery to facilitate the discussion, but it is the peers that are running it. If the group members are leaning on the facilitator to be more structured or be more directive, then the facilitator's role is to kind of say, hey, no, you have expertise here. This is about you. This is about your experience. Let's dive into that. And then, you know, as is the case for any group therapy, there is some role for us as facilitators just to make sure that we are observing group rules, keeping communication respectful, handling it when people leave or have attention, you know, they get drawn away by text messages or etc. So just providing that support in the observation of group rules, which are typically set by the peers themselves. Try not to make this a group therapy group, right? It is peer-to-peer. So here's a nice question. If you're going to share something, a nice phrasing that we've used, we want you to share something, really, we want you to share it from your lived experience. You can use different techniques to get folks talking. So there could be icebreakers that could be helpful. If somebody is appearing guarded or suspicious, you could follow up with their primary clinician so that they could support them clinically, so that when they return to the group, they're perhaps feel more safe to be vulnerable or to share. And you could also integrate art activities or other activities to provide more safety of, you know, provide this sort of activity that then allows people to focus on one thing and then share their experience while they're doing that. And then as appropriate, you might consult with the primary clinicians to better support the client's experience in peer group. The structure of each group is as follows. This is the adaptation that we made at UC Davis. So in the original manual, the group is actually an hour and a half long. We adapted it to be 45 minutes, mostly for accessibility reasons. And so the layout is that we first start by pairing people off in the group, and so they can have a one-to-one conversation. And what we do is we have the pairs share with each other a positive experience from the past week. So one thing that went well, and maybe one thing that they would like support on. Not required, could be sharing one thing that went well alone. And then they come back together and each pair shares what they heard from each other. So I might say, well, I was talking to my peer and they shared that they had a really successful week at school this week and got a good grade on their test. And then my pair would share what I had shared with them. And then all of those things get kind of written on a board, and we sort of think about the theme. What is the theme of things that are happening? What are some theme challenges that people are sharing? What are some theme positive experiences that people are sharing? And then we ask, what have you just heard that could be of interest or help to the group? And then the participants will vote on the selected theme. And then there's a discussion on that theme. And then finally, wrap up reflections and any relevant announcements about, next week, potlucks, events. Some really popular themes that tend to keep coming up in our groups are listed here. What does it mean to live with psychosis? How do we seek support from others? How do I navigate telling people about my illness or my diagnosis? Dealing with particular symptoms like delusions. There's a lot of discussion around dealing with stigma. A lot of discussion around how do we process hospitalization and what that means for me and the trauma that might come with that. Self-confidence, this concept of normal. One thing that's missing from this list, I'm realizing, is also a lot of social questions. People talk about what about dating? What about making new friends? What about social activities? How do you navigate reintegrating with a friendship group that may engage in behaviors that are not necessarily helpful for you, like substance use or going on activities that are triggering or potentially stressful. So that's not on the list. I'll add it when I share the slides, but that's been a really big topic in our group, mostly around dating and creating these new relationships. I will say that one of the kind of bright spots in implementing this guided peer support group in our program has been watching relationships among the clients flourish. We've had friendships develop. We've had folks initiate group-based activities like barbecues and grilling in the park, playing soccer together, going to the cinema, going to events. And we've also had romantic relationships start as a consequence of the guided peer support group. Now, of course, this requires careful management. How do we support these young people in developing their peer relationships without it having treatment interference, or maybe there's confidentiality questions. And it's really just about sitting with those young people and discussing the parameters of how they want to handle it, and a handful of rules as well around what happens in the group versus outside of the group, and how to handle it if some peers are getting on with each other, but not everybody is getting on with each other, and how to manage that. But essentially, the way that we manage all of those things is just through open communication, collaborating with the primary clinicians, collaborating with the people themselves, and again, remembering that the goal of this group is to support peer-to-peer interaction. The world is a lonely place. It can be even lonelier when you're experiencing symptoms of psychosis. How do we support people in building their network? So that's our guided peer support group. As I mentioned, there are some other group interventions that are worth examining, but I think if you had to pick one, my recommendation would be to start there. I want to spend the remainder of my time talking a little bit about treating comorbidities, because I think this comes up a lot, and the documentation on the coordinated specialty care model doesn't necessarily go into detail about how to do this. And I want to talk about two main ones. So the first one is treating trauma in early psychosis, and then the second one is managing cannabis use in early psychosis. So in terms of trauma in psychosis, I just want to review some data that I talked about in part 3 of my CBT for Psychosis series. So we know that there is a much higher rate of trauma symptoms in individuals with psychosis than in the general population. So about 7% of individuals meet criteria for PTSD in the general population, whereas 23% of individuals who have first episode psychosis also meet criteria for PTSD. So that is a big difference. And then we also know that up to 80% of youth who are at clinical high risk for psychosis endorse a lifetime history of traumatic events and victimization during childhood. And a significant portion of those individuals also have trauma-related symptoms that need to be addressed. Secondarily, we know that trauma is poorly diagnosed in individuals with serious mental illness or schizophrenia spectrum disorders, mostly because the differential can be very challenging. Is it a hallucination or paranoia versus a trauma symptom like a flashback or hypervigilance? And it requires a very detailed assessment, and it requires the clinical team to have expertise in both areas. And for various reasons and the way that our training system works, that's not always the case. For example, my training I really focused on specializing in psychosis and schizophrenia spectrum disorders. And it was only later in my career that I took some time to go back and develop expertise in treating trauma symptoms as well, because I hadn't been given a detailed view of that. Now, that might be unique to my training experience, but there is some data out there to suggest that folks in the early psychosis space don't necessarily feel equipped to also address trauma in the context of their clients. We also know that having a history of trauma exposure in psychosis is associated with more severe psychosis symptoms, worse social functioning, increased substance use, increased hospitalization, and increased risk for homelessness and suicide. So it is a big deal when it comes to handling clinical outcomes and treatment success. And so it's not something that we can ignore. So how do we treat PTSD in established psychosis? So we've got multiple studies that show using evidence-based practices that include the element of exposure reduces PTSD symptoms in psychosis. And I've listed some of those studies here. For a couple of things that I wanted to highlight, we know that both prolonged exposure, which is PE, and EMDR reduce PTSD symptoms compared to waitlist control, but prolonged exposure, not EMDR, resulted in the full remission of PTSD symptoms compared to the waitlist control. As a follow-up, I think there's a lot of questions that we have about EMDR as a trauma treatment in terms of what is the active ingredient. And the current consensus in the field is that the active ingredient of successful trauma treatment is exposure. And by exposure, I mean telling of your story and habituating to that story and reframing that story and making meaning of that story and going out into the world and facing the fears that we've developed as a consequence of that trauma and habituating to that anxiety and learning that we can cope with it. And what we know from studies of CBT approaches that don't include exposure is that the outcomes are pretty mixed. So we've got a couple of them that show decreased symptoms and a couple of them that don't find decreased symptoms. And so both studies that I've highlighted here note that exposure is probably the key ingredient. So if you're choosing to do treatment, trauma treatment, make sure it's including some form of exposure intervention. And the theory is that that's the active ingredient in EMDR and PE and TFCBT that is really moving the needle. Just as a follow-up to something that I alluded to earlier, which is barriers to trauma treatment in early psychosis care. Why isn't this happening more? I mentioned that it's hard to differentiate trauma from psychotic experiences. Those symptoms can interact with each other and exacerbate each other, which can make it can feel a bit like a moving target. And then many clinicians report inadequate training, supervision, and funding to learn how to do this. And this is all detailed out in a paper that one of our former students did for their dissertation, highlighted here, that you can follow up on. So with all of this, what should we be doing when it comes to trauma? Well, we should be screening for it as standard, doing a thorough assessment to make that differential, and then applying the appropriate treatment interventions. So in terms of screening, using the PTSD checklist for DSM-5, which is our PCL-5 for our adults, or using the CATS, it's the Child and Adolescent Trauma Screen for folks under the age of 18. These are really good instruments for getting a sort of holistic view of symptom frequency, severity, and an idea of whether this person may or may not meet criteria for a PTSD. There are threshold scores on each of these measures that would say, you know, it's possible PSD, provisional diagnosis. They're not diagnostic instruments, they are screeners, but they are very useful, and I would highly recommend implementing these as part of your intake process if they're not already there. For assessment, if somebody does screen positive on their trauma screenings, you're going to want to do a thorough assessment of those trauma symptoms and then evaluate the context that they exist in. What type of psychosis are they existing in? What's driving the trauma-related response? And making sure you're evaluating complex trauma symptom presentations as well. In terms of treatment, we want to integrate into our treatment for psychosis, into the coordinated specialty care model, empirically supported treatments for PTSD that use exposure. And reduce any cognitive or behavioral avoidance that might be maintaining symptoms. So I've listed some of the evidence-based practices for trauma. We've got trauma-focused CBT, which is a great manualized, modularized approach for individuals aged. I think it's down to 4 now, all the way up to 21. Prolonged exposure, which came out of the VA, which is really focused on the telling of the story, the building of the narrative. Cognitive processing therapy really came out of third wave CBT and really focuses on the cognitive avoidance that's part of it. And then EMDR, which provides a frame to create safety for the person to share their story. And then evidence-based practices for psychosis primarily would fall under the CBT for psychosis category, although of course there are some variations that build on the CBT model, like individual resiliency training. And this leads to the recommended treatment approach that came out of research that we've been doing at UC Davis, which is called Trauma Integrated CBT for Psychosis, or TICBTP for short. As you know, we love acronyms in our field. And this was developed as a collaboration between our early psychosis program at UC Davis and our trauma center, the care center. And it provides this framework for treating comorbid psychosis and trauma symptoms in the early psychosis coordinated specialty care setting. This is a very brief illustration of what it looks like. It's a staged model where you're implementing all of these elements in the circle around over time. So there's engagement is stage 1, then targeted empirically supported treatment is stage 2, and then preparing for graduation and discharge is stage 3. And this is made up of multiple modules that you can follow. And we made a cute little mnemonic for it. It's called A-Care Practice Track. The practice part is straight out of the TFCBT model. It's a great way of applying evidence-based elements for trauma treatment. And then the A-Care and track pieces really try to integrate what we're doing in the CSC model. So things like, you know, doing a thorough assessment, building your case conceptualization, adapting environments and supports, doing the wellness planning, doing the engagement and motivation. All of this needs to happen before you can launch into the targeted treatment for trauma and psychosis, which is always going to include psychoeducation and skill development. So relaxation, affect regulation, and cognitive coping. These are your primary skill developments before you move into your exposure, which is your trauma narration, and then in vivo exposure. So going out into the world and facing those fears. Then there's a conjoint session with family members to kind of orient them and bring them in. And then there's work on enhancing safety for future situations that the young person might find themselves in. And then there's all the graduation efforts that we love to make with our clients as they transition out of treatment. We celebrate successes. We make sure we're doing relationship management and social support. We assess and address any ongoing needs. There might be community linkages that we need to do, and then supporting the practicing and boosting of skills. If you are interested in learning more about trauma integrated CBT for psychosis, the first place I would recommend you go to is to see part 3 of the 3-part series of CBT and psychosis that I did as part of this series. I couldn't find the link for the video yet. I'm not sure if it's up yet. So if it is up, I'd love to request it get put in the chat. And then I can also link it in the slides when I share the slides to go out so that folks have an easy way of getting there. And then the other piece that is discussed in more detail in that seminar is how could you get training in this model? And it would really be about contacting the UC Davis team and seeing what training opportunities they might have available. So finally, I want to talk a little bit about managing cannabis use in early psychosis. In many states across the country, cannabis is now either decriminalized or legalized, and so access has significantly increased for young people. And there has also been a sort of normalization of cannabis use in various communities. And so it's a very common behavior that our clients are coming in with. And for many of our clients, it is an interfering factor in their recovery. And so how do we manage it? How do we address it? And how do we understand it? So first, I just want to just make sure we're all starting from the same place, which is what is cannabis made of? It's made of a lot of different things, but the two things you're probably familiar with are THC and cannabidiol, or CBD is what cannabidiol is abbreviated to. But there are also over 140 other cannabinoids in the plant itself, and research is still piecing those apart, identifying them, and seeing what their impacts are. Thank you. I see Leah has put the link in the chat for the part 3 of the CBT session. Oh, I see. It'll be uploaded in the future. Thank you, Leah. Appreciate that. Now, cannabis can be consumed in many forms. I've listed them here, and those forms tend to vary widely in the amount of THC. And THC is something to be very focused on because, as we'll discuss in a little bit, it is the constituent of cannabis that is shown to exacerbate psychosis symptoms and cause other interfering problems. I think the piece that's really important is to understand that over time, especially with legalization and the development of edibles and the regulation of that, there's been a lot of work done on extracts and concentrates from the plant, which typically lead to very high THC levels, which are given in milligrams on the packaging when people buy them from dispensaries. Whereas if you're buying outside of a dispensary setting, so perhaps on the street, it's much harder to measure what the THC piece is. Here's a list of different cannabis concentrates to be aware of. Mostly these are different ways that cannabis can be integrated into delivery mechanisms. For example, distillate is a refined cannabidiol oil that is used mostly in edibles and vape cartridges, and other pieces can be used in cooking or other delivery mechanisms. Quick comparison of THC versus CBD. So THC is associated with a euphoric high, so it is considered psychoactive. There is some evidence to suggest that low doses might reduce anxiety, but it is very clear that higher doses increase anxiety. It is also very clear that THC exacerbates hallucinations and delusions, particularly suspiciousness, and that the timeline of these things are a bit decoupled. So you might initially experience a reduction of anxiety, but then later on see this worsening of positive symptoms. But that decoupling on the timeline can make it hard for clients to track the sort of antecedent consequent relationship between the using of cannabis and the subsequent impact on their symptoms. And so one thing that's worth doing, and we'll talk about that in a little bit, is measuring how symptoms change over time in relation to cannabis use. CBD, on the other hand, is not psychoactive. It doesn't tend to lead to a euphoric high. There is evidence to suggest that it may reduce anxiety. There's evidence to suggest that there are possible anti-inflammatory effects. It doesn't appear to have an effect on positive symptoms of psychosis. There's some very interesting research out there that has led to official FDA approval of CBD as an anticonvulsant, so a treatment for severe epilepsy. It is at very high doses. Not doses that you would find in commercial products. And then we also know that there's a handful of side effects like sedation, sleep disturbance, and diarrhea, so things to consider. And I think it's worth knowing the distinction between THC and CBD because many of you may have been exposed to an increase in products that are available over the counter that have CBD in them, even for your pets as well as for yourself. And there's CBD oils and moisturizers and tablets and CBD drinks. And so it's just being aware of how it's different from THC and how it may or may not impact symptoms. I want to take a moment to talk about how cannabis has changed over time. And the little tagline of this is that today's weed is not your parents' weed. It's not the weed from the 70s. It is very different. What this graph is showing is the rapid increase in the THC concentration of cannabis that is mostly sold on the streets, although it does include, the later years do include commercial use. And you can see a big jump from 2 milligrams all the way up to 18 milligrams average in kind of 2017. The latest data that I saw is commonly now, it's greater than 20% concentration. So it's a lot. Very, very high THC in the products that are out there today. And there's also been an increasing THC to CBD ratio. So the most recent data suggests that there's a ratio of 120 units of THC to 1 unit of CBD. So it's very, very powerful psychoactive component that is known to exacerbate psychotic symptoms. Now that we understand what cannabis is, I want to talk a little bit about what cannabis use looks like in psychosis. So depending on the study that you read, anywhere from 20% to 70% of clients with schizophrenia report cannabis use. There is some variation here based on national location. Use is higher in states where it's decriminalized, et cetera. And we know from the data that cannabis use increases the chance of developing psychosis by 5 times. And I've got some more detailed data in a second that breaks that down a little bit. 1 in 2 individuals with schizophrenia report lifetime use, and 1 in 4 report abuse or dependence. So that's a distinction between use versus use that interferes. So it's a high percentage of your clients that are coming in with this challenge potentially. There is some really interesting data that came out of some researchers in London, primarily by an Italian researcher, De Forti, that looked at the relationship between cannabis strength, so that THC component, and psychosis risk. So we know that the use of cannabis significantly increases the risk of developing psychosis, and that the more THC is in that cannabis and the more frequent the use of that cannabis, there is an ever increasing risk. So you can see that here in this chart, that you can see that for folks who've never used cannabis, there's a much lower risk than for folks who use strong cannabis daily. It is a 5 times greater risk compared to a non-user of developing psychosis. And this is a key bit of information. In fact, the data that came out of this paper showed that daily users of high potency cannabis were 5 times more likely to go to hospital with a psychotic episode. So not just having a psychotic symptom, but having a severe enough presentation that they would need to go to hospital. There's also an association between age of cannabis use and psychosis risk. So the earlier a person starts using cannabis, the greater the risk for developing psychosis. And I think the big thing to hear here is that use before age 18 is associated with a 4.5 times, for the age of 15, associated with a 4.5 times increased risk. Anything before 18, you've got a kind of 1.6 increased risk, and then never used is considered kind of, you've got this kind of baseline risk for psychosis in the general population. So you've got the sort of strength of the cannabis and the age of first use of cannabis are these big predictors of outcomes. So how do we treat this? What do we do? So for folks with psychosis, cannabis use is often a method of trying to tolerate distressing symptoms, for example, anxiety or emotion dysregulation. But we know, based on the discussion I just gave you, that cannabis often has other negative consequences. So increased positive symptoms, but also like potential legal consequences, depending on the state that they're in and how old they are, and then physical health consequences, depending on how they're consuming cannabis. And so our treatment recommendation is to develop replacement skills that help clients manage their symptoms or tolerate the distress that don't have those negative consequences. So instead of using cannabis, can we use something else? Can we do something else to help you feel better and manage that anxiety? And then also working on supporting clients in navigating social situations around cannabis use. So one way that we've supported some clients in who are reintegrating with their social circles who do use cannabis is to sort of develop this kind of allergen story, where they say, hey, like, you know, my body, my brain happens to have somewhat of an allergic reaction to cannabis, and it gives me these bad outcomes, and so I don't want to engage in it anymore because it makes me feel bad. And that can reduce peer pressure and use, without necessarily requiring the young person to talk about their mental health history. And so in terms of how do we do this, here are some treatment options. So it's very clear from the literature that a harm reduction approach is best. So use motivational interviewing techniques to support change strategies. We recommend offering substance use management groups for clients that has this harm reduction approach, and some distress tolerance skills and education included. If substance use services are outside of the scope for your clinic, working with community partners who can provide those services, make sure those community partners have an understanding of psychosis. So your team may need to go out and do some educational and community outreach work so that they're able to administer their substance use services in the context of psychosis. It's worth acknowledging that rural settings and urban settings may have different needs, so making sure you're considering that, and really taking all of this in and discussing what's the best way for your clinic to address this. There's no one size fits all. I think the take-home message is we generally don't want our clients with psychosis to be using cannabis because it has bad outcomes for them, and we want to take a harm reduction approach in supporting them in moving towards more healthy behaviors. Just in case harm reduction isn't familiar to you, I put a couple definitions in here. Harm reduction is a set of principles and strategies that are aimed at reducing the negative consequences of substance use. So it's different from an abstinence-only approach. It's about reduction. And it recognizes that there are some ways of using drugs that are clearly safer than others. And so how do you support your client in safe use? So some clear examples of harm reduction strategies in cannabis use are listed here. So you could encourage the user to change the type of cannabis that the client to change the type of cannabis that they use. So can you move from high THC to low THC, or products that are mostly focused with CBD? You probably want to talk about reducing safety risks. So making sure you're identifying safe and legal ways of obtaining cannabis to prevent negative consequences. We already know that the young people we work with are more vulnerable to being drawn into the justice system, and then the consequences of being in the justice system tend to be pretty negative on their mental health outcomes. So how do we set them up for success to avoid a justice system involvement? And then you're going to want to work on reducing health risks, so identifying ways of consuming cannabis that reduce the risk of negative health consequences. So reducing smoking, it reduces cancer risk. The young folks that we work with, they're already commonly taking medications that have big side effects, that have implications for their quality of life outcomes over time. Let's access other behaviors that we can reduce those health risks from as well, to just build that quality of life in the long term. And then involving support buddies. So if they're in social situations where substance use is happening, how can a support buddy be there to help reduce use or prevent use, or provide support in giving that story, about allergen use? How can a support buddy help that young person reduce the harm of using cannabis? I've listed some distress tolerance skills for substance use here. The tip skill, this is straight out of DBT. If somebody is very distressed, they can use the tip skill to bring that distress down quickly instead of using substances. They might also want to engage in a pros and cons skill of changing cannabis use versus staying the same, and then doing some radical acceptance, accepting reality as it is. My brain is not suited to cannabis use. When I expose my brain to cannabis, I experience symptoms and I don't feel well. And then radical acceptance of, I want to reduce my suffering. I want to build the life worth living, and that might require me to change my behavior. There's some other distress tolerance skills that we might want to be using. The accept skills really talks about how do we move forward from substance use. Improve is really about changing your mood in the moment, and then self-soothe, of course, is also changing your feelings in the moment rather than reaching for substances. If you are interested in understanding more about cannabis use in psychosis, I encourage you to watch this, I think, hour-long presentation that came out of our group at UC Davis that provides a much more detailed set of information around the topics that I covered today, and really gives you a sense of, what's the effect of cannabis on the developing brain, what are some ways that cannabis is being researched as a potential treatment opportunity in other spaces. It's very informative. It's a great video, and it has been designed to also be suitable for clients and parents, so you can share it with them and watch it together and maybe answer questions. And I've linked it here, and it's also linked on the UC Davis EpiCal website, YouTube channel, which I have linked in prior seminars. Oh, here we go. So with that, my closing remarks, I've got a list of a few things that I didn't have time to cover today. So I wasn't able to cover individual resiliency training or IRT. This came straight out of the Navigate program. I've linked the information on this. It's got a great manual that's written very clearly. So if you haven't had exposure to it and you're interested in learning, I encourage you to go look there. What I like about IRT is that it's very modularized. It's got great worksheets, and you can sort of steadily work through it with a client if the client likes that approach. I didn't get a chance to talk about cognitive behavioral social skills training, or CBSST. This came out of UC San Diego group. It's a lovely manualized approach that really focuses on helping the client develop skills that then help them build their social network or repair their social network. I also didn't get time to talk about cognitive remediation or brain training, which has been a relatively new development in the research space that is designed to support improvement of cognitive impairments and social cognitive impairments in psychosis. And then finally, there's a lot of research that's been happening around mindfulness-based cognitive therapy, which is really part of the third wave treatment approach. And I've linked a really nice review of that here for those of you who are interested, because there's lots of different variations of mindfulness-based interventions that you could choose to look at if you wanted to implement those as part of your program. So thank you so much for listening. I'm going to pause here. We've got about 20 minutes for questions. I would encourage you to think about if there are questions about any of the material that I presented today where I can offer clarification, or questions about clients that you're thinking about and how you might want to integrate some of the information here. Could be system level questions, administrative level questions of how you might bring in new interventions, or really any other question that's relevant for the work that you're doing in this early psychosis space. So I'll pause and I'll give you a chance to either write it in the chat or unmute and shout it out. I'm hoping that somebody is feverishly typing away in the chat a question. Another option as well is to share other ways or other interventions that you've integrated in the work that you're doing with your early psychosis clients that maybe I didn't cover, that have been successful for you, that your colleagues on the call could learn from. Thank you, Trisha. How long has prolonged exposure been used, and is there training for this? Great question. I don't know the precise date that prolonged exposure was developed, but it did come out of the VA. And when the VA has a very thorough treatment development process, so and I know that it's been around for at least the past 20 years, because that's when I learned about it, so, but probably longer. And the VA do offer trainings, both online and in person. And there's a couple of really good manualized books as well. So one of the books that I have found helpful comes from the Treatments That Work series. And let me just see if I can pull up the link. Treatments That Work from the Oxford University Press. They're very accessible. They're written out. Let's see. I'll put the link to, there's a lot of really great manuals on this website, so I'm going to put the link in the chat for you. And I'm just looking at, oh, and they've got here we go. Concurrent treatment of PTSD and substance use disorders using prolonged exposure. That's a great, great manual. Let's see if I can find the PE. And we'll do this while we see if there's another message. Prolonged exposure is an interesting model. It really focuses on developing the story and has the person kind of record their story and listen to it as part of their homework. The prolonged exposure protocol has very minimal skill development before the exposure starts. And so this can be, for some clients, this can lead to some flooding if they don't have coping skills already set up. And so one of the adaptations that I have made when working with clients who have complex psychosis symptoms that interact with this is I first spend some time developing coping skills with them that they can use if they do experience, extreme distress as part of their exposure, and then going into the prolonged exposure. And that's something that the TF-CBT model does really well. So it's something to consider as you think about implementing. Any other questions? Okay. There we go. Okay. So this is the link to the prolonged exposure manual, and then they've got a couple of other ones. They've got prolonged exposure for adolescents, which I actually haven't looked at this. I wonder if that has more skill development up front. And then prolonged exposure in intensive outpatient programs. So I'm familiar with the first one. I haven't spent time in the second two links. And there are workbooks that come with the therapist guides. Any other questions about today's materials? Okay, if there are no other questions, Leah has posted in the chat the information that you need to get your CEUs. Please click on the link, and you first need to complete the training evaluation form, and then you'll get to the following page where you get to claim your CEUs. So I encourage you to do that. I always appreciate the training feedback. I like to get better at my job, and the only way for me to do that is to get constructive feedback from folks like yourself. So any feedback or requests that you have would be most appreciated. And with that, I say thank you for your time. I know that you are all busy humans working hard to support the clients that you care about. I want to say thank you for your time. Thank you for your contribution to the community. Thank you for the work that you do. And I hope that you took something away that's helpful for you today.
Thank you, Dr. Tully. I'll hang out on here in case anyone has any issues with the CEUs, but like she said, the link is in the chat.
Yeah, thank you. And Leah, I will package the slides and email them out to you probably end of day. I want to add in a couple of these links that people asked about, so that they're there and accessible. And then I'll send them to you for posting alongside the video.
Thank you so much.
Appreciate your time, and email me if you have any other needs regarding today's session.
Thank you.
Thanks, everybody. Have a great Wednesday. Take care of yourself.